つで大丈夫ですか？
はい、大丈夫です。
Okay. Okay. Now we will start with the Q&A for Dr. Otani's lecture. And thank you all again for sending us many questions. Dr. Otani, we have several questions for you. First question will be, what is your opinion regarding use of single mid palatal screw instead of two PS screws?
Okay, thank you for good question. My main purpose to decide the upper molars is going through at the residence center of residence of upper six. So at the when we put on the mid-palatal area mini screws cannot go through the center of resistance of upper six. So when we put on the mid-palatal area, so we have to use a long hook to retract to go through the retraction force. So in the lingual appliance, we often use the we often place the mid-palatal area or mini screws and solder long hook with main arch wire in lingual side, lingual appliance, and we retract by power chain. But in labial appliance, we always often place mini screws at the palatal side, as I shown. Yeah, it's okay.
Of course. Thank you for answering. And I'll go on to second question. What is your opinion regarding carbon nitride wire as compared to nitrile wire?
So thank you, Dr. Mohad. But I'm sorry, I don't know the carbon nitrate wire. I guess to bend bending nickel wire like that, but I don't know exactly the carbon nitrate wire, so I cannot answer your question exactly. Sorry. So if you have some information, please chat to my message directly. I'm sorry. Thank you.
Okay, Dr. Mohad, please send us more information. Then maybe Dr. Otani could answer your question more easily. Okay, I will move on to our next question. What is the consideration between placing pads on 5 and 6 and 6 and 7 on buccal side for destabilization?
Sorry, I cannot see this question, Rachel. So where where is
I sent you direct message.
oh really? Direct message, not Q&A, right? Okay, I will check it. What's the consideration between placing tats on 5 to 6 and 6 to 2 on backer side for digitalization? Okay, so I always place between 5 and 6 in both jaw and upper and lower side, because between root length is big, between 5 and 6, so it's easy and to avoid the root contact with mini screws. So I always use 5 and 6. Yes, that's right.
Okay. Thank you, Dr. Otani, for answering the questions. Do you have any other comments for our listeners tonight?
Mm, I can check the, I will see the, one more question. What is the most common type of dual top
Oh, okay.
using?
What is the most common type of dual top head using on palatal area? What is your most commonly used screw?
So, Dr. Kim, as he already said, he always use maybe JA type. I also often use JA type on the backer side and the powder side. It's a very usable to use a power chain, coil spring. It's very easy to hook. So I always use a J type. For example, when we place the mini screw at the retromolar part, I sometimes use G1 with without the base. Is that Rachel? Is that okay? G1 type.
Yes. G1.
One. I forgot that G1 or G2. It's no base with screw head.
G1.
G1 type.
Yes.
So at the retromolar part area, I sometimes use a G1 screws. Yes.
Thank you for answering all the questions, Dr. Otani. Uh, and thank you for preparing your lectures. uh, okay, now we will have a 10-minute break time. We will start our last lecture with Dr. Shintaro Okashita from 10 minutes from now. That will be 9:42 p.m. Thank you. I hope everybody is back from their break. Uh, I would like to introduce our last speaker of today, Dr. Shintaro Okashita. Dr. Shintaro Okashita is Chief Director in Okashita Orthodontics in Nara, Japan. He completed his PhD course at Osaka Dental University in 2005, and he was an assistant professor at the Department of Orthodontics from 2007 to 2012. He opened his own orthodontic clinic in Nara in 2007. He was an adjunct lecturer at Kyunghee University in Korea. Also, his focus field is a lingual orthodontic treatment and a main lecturer at the seminar of Geomedical's Japanese distributor, Proceed Corporation. The title of his lecture tonight is How to Use TAD in Lingual Orthodontic Treatment. In this lecture, Dr. Okashita will introduce the mechanics of lingual treatment and show us how to apply in cases.
How to use TAT in lingual orthodontic treatment. Good evening. How are you all doing? First of all, I would like to briefly introduce myself. My name is Shintaro Okashita and I'm 48 years old. I've been practicing orthodontics in Nara for 15 years this year. I moved to this building 5 years ago and now have 20 staff members. The second floor is the treatment room, and the third floor is dental laboratory, my room, staff room, and storage. After the moving, I also opened a Japanese izakaya on the first floor, but it failed and my izakaya disappeared. Oh, I've changed my mind. This is the interior of my office. It is brightly decorated with white and blue as base color. This picture shows many chairs. You can see 1, 2, 3, 4, 5, 6, 7, 8 chairs. But it is mirror magic. In truth, there are 5 chairs in total. Let's get down to business. There are many patients who want to be invisible. The two most common types of invisible systems are ringer braces and aligners. However, aligner orthodontics has many limitations, and in extraction cases, ringer orthodontics is clearly more applicable. First of all, let's review the mechanics of ringer orthodontics, which may sound boring to you. The figure on the left shows a labial bracket on an anterior tooth with an intrusion force applied. The right figure shows a ringer bracket on the anterior teeth with intrusion force applied. As D1 shows, in the labial bracket, there is a horizontal distance between the bracket and the center of resistance. On the other hand, in the ringer bracket, as shown in D2, the bracket and the center of resistance are very close to each other. Therefore, the moment of labial crown torque is larger in labial orthodontics, while the moment in ringer orthodontics is significantly smaller. The figure shows the anterior teeth of 3 different tooth axes. In A, the bracket is located toward of the center of resistance. In B, the bracket is horizontally at the same position as the center of resistance. C is case like class 2 division 2. The bracket is located behind the center of resistance. You can see the yellow line stretching vertically like this. Let's assume that we apply an intrusion force to the center of each bracket. The moment shown by the red line occur at A and C. At A, here the bracket is anterior to center of resistance. The moment of crown ringer torque occurs while the tooth is intruded. At B, the moment does not occur and the tooth just intrudes straight. At C, the bracket is positioned behind the center of resistance, so the tooth tilts linearly with intrusion. Therefore, it is difficult to apply crown ringer torque with ringer orthodontics for tooth axes like B and C. In this way, ringer orthodontics tends to cause easily undesirable rabbiting in clinical practice depending on tooth axis. For idea on how to solve the problem of controlling the anterior tooth axis in ringer orthodontics, Dr. Horn's lever arm article published in Angle also in 2005 is a good reference. As you can see in the figure, let me explain about it. In the upper blue, the length of lever arm is at the same height as the center of resistance. And the tooth axis of the anterior tooth does not change. The vertical movement of the teeth is shown from left to right. Intrusion, parallel, extrusion. However, such a lever arm that is too long is often difficult to use clinically. In the middle red, the length of lever arm is located below the center of resistance, so the tooth axis shows a ringer control tipping. This mechanics is often used to actual clinical practice. It is especially suitable for class 2 division 1 and bimaxillary cases. In the lower green, the length of the lever arm is located at the center of resistance, so the tooth shows a lateral inclination. So theoretically, the long lever arm can prevent the ringer tip of the anterior tooth, but it is not always applicable in actual practice because of the palatal shape and the tat position. I'm sorry to be so difficult to talk about. I know you are so tired. Me too. Now let's talk about the case study. Here is today's menu list. The use of tats in ringer orthodontics is divided into 3 main patterns, which will be introduced with cases. The first 2 are the most common cases to tooth extraction. The first one is a pattern with a lever arm attached to the main one, and the second one is a pattern of simple traction from the labial tat. Finally, a severe case of tat with fixed median palatal suture. Lever arm case. Case 1. This is a moderate anchorage case using a lever arm dwelling closure and extraction space. This is a skeletal class 2 angle class 2 deep bite case. The patient is a 26 6-year-old female, and her chief complaint is lateral profile. The interval finding shows an end-on plus 2 molar relationship with protrusion of the maxillary anterior tooth. The patient's lateral profile is convex and the upper lip is protruding. Panorama. Upper and lower wisdom teeth can be seen. Cephalometric analysis. NB of 5.5 degrees, FMA of 23.5 degrees, and interincisal angle of 108 degrees, indicating a pronounced lateral inclination of the upper and lower tooth axis. The treatment plan was as follows. Because of a small FMA and overbite, and the acceptable linear inclination of the mandibular anterior tooth axis, I planned a class 2 finish for extraction of the maxillary first premolar. Three months after the start of treatment, the maxillary first premolars were extracted and the upper and lower arch was leveled. 6 months. The maxillary wire size was set to 017 by 025 stainless steel wire, to which a lever arm was attached and traction was started from the top. This case is from the old days, so it used dual dimension wire, but I don't use that now. Currently, I use 017 by 025 stainless steel for retraction. The lever arm is screwed from the top, located above the center of resistance to a position lower than the center of resistance. Therefore, the tooth move centrifugally with tipping and pressure drop lingually. This is the area surrounded by red. In continuing with space closure, the bite up is removed as soon as the class 1 relationship of the canine teeth is achieved. The space on the left side is still intact. The lever arm is also removed and the space continues to be closed. Class 3 elastic are being used to apply the mandible as the space denition is closed. The device has been removed. The canine occlusal relationship is class 1 and the molar occlusal relationship is class 2 finish. Panorama at the end of treatment. The wisdom tooth has not been extracted yet. A slight improvement in the class 2 relationship is observed. The tooth axis of the upper and lower anterior teeth has improved and the interincisal angle shows good values. Profile. A good smile line and side profile has been achieved. This is a change in profile before and after treatment. The protrusion of the lip has been improved. This is a retention after 8 years. The occlusion is stable. Good. In this case, the use of short lever arm allowed for controlled tipping and reduction of the anterior teeth. In clinical practice, a long lever arm may be difficult to use due to the shape of the pattern. Here is another case where TAZ was placed between the first and second premolars. I'm using a lever arm from Dentos in Korea. This type is my favorite right now. This is a case of using a middle lever arm. In this case, the tat was placed between the first and second molars. This is an MSC case with maxillary teeth adjusted so a long lever arm is used. The case, 4 tats were placed in maxillary base. Since the palate varies from patient to patient, it is better to have several different lever arms. My favorite is the Dentos lever arm. Dentos lever arms are available with 2 to 4 different hooks. This may look complicated, but it is easy to adjust and cause less discomfort to the patient. I have purchased the lever arm when I attended KAO. I couldn't attend KAO because of Corona, so I ran out my stock. I ordered it the other day via email. Next case. It is labial retraction, case 2. This is the second case. This is a method of retraction from the buccal side. This is a moderate anchorage case, skeletal class 1 by maxillary protrusion. In the oral photo, you can see the labial inclination and minor curving of the upper and lower anterior teeth. Facial profile photo. The frontal view is fine, but the lateral view shows a complex type with protrusion of the lip. Panorama. The upper and lower implant wisdom teeth are visible. Cephalometric analysis. NB 5.5 degree with tendency to class 2. FMA 23 degrees with slight tendency to deep overbite. The upper and lower anterior teeth show significant protrusion. Here. This is a case of extraction of upper and lower premolars. It is treated plan. All premolars are extracted and leveling is started. After leveling is completed, tat is placed between the root of the buccal molars. Tooth close, detailing and finishing, retention. Leveling stage. A linear arch for distal movement is attached to the fixed source of the macula. It was not used in this case. This is another mechanic that is often used to move molar distally. It was invented by Dr. Haruya Ogawa in Hiroshima. In this case, the molar relationship was class 1, so it was used not for distal movement, but for holding the extraction space. Leveling is complete at 10 months, and the upper and lower wire are up to 017 by 025 strength steel wire. Very simple mechanics. As you see, the button is placed distally on the cervical of the canine. I'm pulling the button from the buccal molar tat. The red dot indicates the center of resistance of the canine. Therefore, in this case, the tat and point of action will both be lower than the center of resistance, which is indicated by the red box. Therefore, the maxillary tooth attaches smooth, centrally with controlled tipping. The stainless steel wire is made of cobalt chrome alloy. It requires heat treatment, but is easy to bend. Bend it according to this chart. A few things to consider in traction. 1. The space for the wire in the distal of the canal is covered with a resin that contains a lot of filler. In addition to the above, the button is positioned distally, not centered, to prevent a distal movement. It is a resin that contains a lot of filler. This is O3. The shutter on the bracket is ligated with a module to prevent the lid from opening in traction. It has been 8 months since I started traction. The space has been closing steadily. The torque of under teeth is not lost too much, and the proper tooth axis is maintained. The brackets were removed after 24 months, exactly 2 years. The space in its upper and lower dentition were completely closed and a good occlusion was achieved. Facial profile photo. You can see a beautiful profile. Improving the profile, lip closure is important aesthetically and in terms of corona infection. Comparing the cephalometric image before and after, we can see that the maxillary under teeth determine the position of the upper and lower lips. Post-treatment panorama. The mandibular wisdom tooth should be extracted as soon as possible. There is clear improvement in the tooth axis of the upper and lower teeth, and the protrusion of upper and lower lips has been improved. Photo after 3 years of treatment. Occlusion is stable. This is a facial photo. Smile line and profile are good. She is our DH and has recently given birth to her first son. This is a superimposition after retention. It has only been 3 years, but it is still stable after retention. Up and lower superimposition. The maxillary teeth show moderate tipping and distal movement with slight intrusion. Comparison of label and Bringer site mechanics. Advantage is here. Disadvantages. Next, Ringer site with Ringer arch technique. It is indirectly activation. Advantage is here. Disadvantage is here. Ringer technique is indirectly, and there is a distance between the screw and the bracket. It is difficult. Case 3. This is a last case and a high angle open bar case. The patient is a 20-year-old female and her main complaint is that she cannot bite with her under teeth. The molar relationship is angle class 1, but there is an open bite and clubbing in the upper and lower teeth. The upper and lower teeth are also protruding. Profile. You can see protrusion of the upper and lower lips. Wisdom teeth are present on the right side of the maxillary and on both sides of the mandible. The maxillary sinus is low. It is often difficult to retract the anterior teeth in these cases. So it is necessary to confirm with CT beforehand. Let's have a look at the lateral cephalo. The FMA was 37.5 degrees, indicating a severe high angle. In addition, the anterior teeth were tipped to the lip and the anterior teeth showed an open bite of 2 mm. Treatment plan is followed. 1 month, leveling has been started. In this case, 2 screws were placed in the median parotid suture of the maxilla. The median parotid suture has the highest bone density of the maxillary palate and is suitable for cases that require strong fixation. It is isolation. Isolation is a system developed by Dr. Itsuki in Tokyo. There are 5 different types of isolation. Now, here are 2 of the common types. This type 3 can easily be used for many mechanics such as reduction of the canine and control of the second molars. In this case, type 4 was used for intrusion of molars. Leveling stage. Intrusion force is applied to the maxillary molars. The molars are intruded and misaligned with the bicuspid. Bracket on the maxillary buccal side to correct the step. This is a change after 6 months of applied intrusion force to the molars. The molar are intruded and misaligned with bicuspid here. Next, closing the space between the upper and the lower arch. We continue to close the space. The shape of the attachment where it's being changed. This is the final detailing. Up and down elastic applied to the anterior teeth. It took some time. After exactly 3 years, the brackets were removed and the treatment was completed. Panorama. Post-treatment cephalo. The post-treatment cephalometric data showed that the FMA decreases by 2.5 degrees from 37.5 degrees to 35 degrees. And counterclockwise rotation of the mandible occurs. The tooth axis of the upper and lower teeth has improved. Let's look at the superimposition of the upper jaw and the lower one. Here, it's maxilla. The molar was intruded by 1 mm and moved majorly slight. Mandible. 2 mm major shift and 1 mm intrusion at the crown. 1 mm measure applied for molars here. It's very important. Oh, this is a lateral view of the initial and finish. Now, focus on the occlusion of the molars. What are the conditions under which counterclockwise rotation of the mandible occurs? 1. Maintenance of vertical axis of maxillary molars. Uprighting of the root of the mandible molar in the measured direction. 1 plus 2 is 3. 3 is decrease in the occlusal height of the molar is occurring. Simply applying an intrusion force to the upper and lower molars does not result in a counter. It is more important to establish a good occlusion between the occlusal head and the force by controlling the appropriate tooth axis and the upper and lower molars. Pre-treatment and post-treatment Cephalo. In addition to the protrusion of the maxillary anterior teeth, the counterclockwise rotation of the mandible helps to improve the open bite. This is her post-treatment facial expression. I feel like I've gone from a student to a working adult. Nice smile and good profile. You can see an improvement in her profile. Today, I have introduced 3 mechanics used in linear orthodontics. The lever arm can control the torque of the anterior teeth, so it can be adapted to many cases and very useful. Reduction from the buccal side is simple in mechanics and easy to use. It is very effective in suitable cases. The third, the median palatal suture is used in more difficult cases. The device is a little more complicated, but it can solve many clinical difficulties, vertical, horizontal, and so on. They are my 2 older brothers and my mentor in Korea. I haven't seen them in a long time either. My office is located in Asuka, Nara. Asuka is the oldest capital of Japan and historically a region with strong cultural influence from Korea. Please come and visit me after Corona is over. I wish you all good health and happiness. Thank you very much for your attention.
Thank you, Dr. Okashita, for preparing your lectures. Again, we will have a 5-minute break time. If you haven't done writing the questions, please write it in the Q&A.